Okay, Assalamu alaikum everybody. My name is Hamna. I'm a medical intern, and today I will be taking the lecture, Coma and Related Disorders of Consciousness. So before we get deep into what is coma and what are the other diseases that we will be talking about today, let's start straight from the basics, and then we'll go deeper into each one of the specific topics. But I want you to keep in mind that this is a very broad topic where you have ton of explanations. I'll be very specific to the highlighted important things at which will be asked for your exam. What is the clinical point of view that you should be, that should be at the top of your head, and what are the possible questions that you can get from these topics? Because although it's a vast topic, at the medical student level itself, there's specific things we're supposed to know, and those are mandatory regardless of our level. So let's get into the topic. So when we talk about coma, what do we mean? We mean that the patient is no longer conscious, right? So what does consciousness mean? When we talk about consciousness, the term itself, the consciousness is the amount of how awake is a person, like how conscious is the person. But when we talk in specific into the medical terminology, we have components of it that classifies what is consciousness, right? So there are three main components. The first one being arousal. What do we mean by arousal? Meaning how alert and are we in, for example, how alert does a person look? Right? So we have the subclassifications of arousal as well. But arousal in essence means, for example, if I look at you, are you looking back at me? Are you conversing with me in a normal person way, etc. is arousal. All right. Content is basically the sum of cognitive and affective function, meaning how memory skills or the rapport in speech. For example, what I'm doing right now is from my cognition, right? I'm trying to tie topics together and I'm delivering a topic lecture basically. So this is from my cognition, right? And the sleep wake cycle. Nobody can go on for too long without sleep, no matter how hard we type. And then we eventually wake up and then we have the whole cycle over and over again. This is called the sleep wake cycle. So the sum of these three, arousal, content, and the sleep wake cycle, make up the entire topic of consciousness. All right. So when a person has all three of them, we call them completely conscious. When they lack one or more of these things, then we start classifying them accordingly. All right. So when we talk about the level, so we spoke about the content of consciousness. Now we talk about the level of consciousness. When we talk about the level of consciousness, it's divided indirectly into two things. It's arousal and awareness. We already spoke about arousal, and uh, basically awareness is a subtype that we can classify it based on the level. So when we talk about arousal, it stems from the brainstem. And awareness is basically from the cerebral hemispheres. You can directly correlate where the location is in the brain to the function of it. So when we talk about the brainstem mainly classifies the cranial nerves, right? So you can and all of the tracks, your spinothalamic, your dorsal column, all of them pass through the brainstem, right? So arousal contains for the eye opening and closing, and like I said, when I talk to someone, for example, if me and person X are having a conversation, the way they respond, the way they communicate, all of this is part of arousal, right? And motor responsiveness. How well can a person respond in terms of motor activity? Awareness is the rest of the thing. Your awareness to your surrounding, your awareness of where you are. For example, you'd behave differently if you were in a classroom or a lecture hall. You'd behave differently if you were in a mall, right? This is your orientation to place, to location. This is basically part of awareness. Your memory, your judgment skills, your knowledge, all of them are part of your awareness, and this is mainly controlled in the cerebral hemispheres, whereas more of the action and all of those, your reflexes, etc., are controlled in the brainstem itself. So this determines the level of consciousness. For example, if a person is a person extremely conscious, for example, some patients, they won't be able to open and close their eyes spontaneously. This could indicate that they are in a different, their level of consciousness is decreased, right? So in this lecture, combining the content of consciousness, the components of consciousness, sorry, and the level of consciousness, we will be classifying different types of diseases related to coma and coma itself. So moving on, what is coma? So when we talk about coma, what is coma? We've all heard this term at least once in our life, either through somebody we know who is affected by it, or through movies or series, etc. But we've all heard the term coma at least once, right? So what is coma? Coma is basically reduced alertness and responsiveness. All right. And it could be continuous, it could be intermittent, or it could be a patient goes into coma, eventually recovers, or they're just going and deteriorating, becomes vegetated, etc. Okay. So it's basically a deep sleep-like state from which the patient cannot be aroused no matter what. You can try reflexes, you can try uh, basically stimulating different things that we spoke about, like the eye opening, the motor responsiveness, and the patient would not wake from this deep sleep-like state, right? On the contrary, what is drowsiness? So when we classify them in different states, it would go something like this: drowsiness, stupor, coma, vegetative state, brain dead. Okay, so this would be the classific, if we were to put a level to the consciousness related diseases, this would be the how we would classify them. So let's start with drowsiness, the first one on our table. Drowsiness, almost all of us have gone through it, or like are going through it in some format, meaning, for example, when you're in the 6th or 7th lecture of the day, some of us automatically feel drowsy. It's completely normal, right? Or you're going on the 17th or 18th hour of your day with no sleep, you're automatically drowsy. So it's just light sleep, it stimulates light sleep. But if somebody wakes you up, your friend taps you in a lecture hall, you're immediately awake and alert, right? So it's brief periods, it's not a continuous state. You can basically be put back into proper level of consciousness. And this is not something that is worrying unless there is an indication for it. The next is stupor. So the second one is stupor. This chain will actually help you understand the progression of consciousness related diseases. Okay. So the next one is stupor. In stupor, it's most likely the patient this is not normal. This is not normal in terms of the common population, but the patient can only be awakened by painful stimuli. What do we mean by painful stimuli? Sometimes patients, if you try to tap them, wake them up, they don't come out of it. They're not just drowsy, they're in deep sleep-like state. But are they in a coma? No, they're not in a coma. So what are they in? So when you actually, right now, currently it's illegal to pinch any patient, so don't do it, please. But the idea is you inflict pain. So right now, the correct method is actually to take a blunt object like a pen, or you can take the back of a reflex hammer and you press on the sternum or the eyelid bone, basically the orbital bone, eyelid bone. Okay, so you press on one of the bony components and they'll wake up. This is a stimuli where they'll actually have a response to. All right. In the olden times, a pinch was allowed, but obviously that's, harming the patient. So we no longer do it and it's prohibited. So the patients can be awakened by a vigorous stimuli, and because they're trying to avoid it, this is pain. And when anyone goes through pain, what do? We try to avoid the stimulus, right? Same component. So they'll shake their hands, they shake their heads, they'll try to jerk a bit so that they can get rid of this uncomfortable stimulus. This is stupor. So this is the second one. So we've seen two of them, right? Before we go into the other further ones, let's try to understand how our nervous system itself works. How is our consciousness and how is all of that working? The main controlling thing that controls how our sensory inputs are regulated, how we respond to them, is the reticular activating system. If we lose the reticular activating system, that's it. The patient is as good as dead, and it actually has very, very poor prognosis afterwards. Meaning, quality of life, the chances of living, all of that goes really, really down. Okay? What does the RAS do? So the RAS is basically located here, and it's along the areas of the brainstem, and it receives multiple sensory input. Where does it receive this input from? It receives the input from everywhere, from the eyes, from the ears, from the tracts that pass through, everywhere, and it projects it to the thalamus and cortex. It projects it outward, like so. And after the cortex processes the information, the thalamus processes the information, it projects it back into the RAS. So the response also comes from the RAS downward. Okay, so this is why the reticular activating system is extremely important and crucial. So it's kind of like a gate. So it is a gating system. It can either increase or decrease the stimulus. So something that I find very fascinating is you can see sometimes when someone is constantly exposed to a certain type of stimuli, they eventually become numb to it. So, for example, some people, they're going to react differently to 50 degree, if they touch water that is 50 degrees, rather than to other people who touch the same 50-degree water. It's very common. Some people can actually tolerate heat in much better forms than other people. We've all got different types of tolerance, right? This is because basically of the reticular activating system. It acts as a gating system. It can increase or decrease based on the stimulus that it is used to. And it also affects the thalamic inhibitory. This will eventually affect the thalamic inhibitory effect on the cortex itself. It alters the ascending, meaning what, sorry. It affects the ascending stimuli that goes to the brain, meaning to the cortex, etc. And it controls what comes down from the cortex itself as well, meaning what is the response. Like if I'm touching like water that is 50 degrees Celsius, maybe maybe my friend will take her hand away immediately. Maybe I'm used to the 50 degrees, so I will still keep my hand as so because it's fine for me. I can drink coffee that hot, right? So that's the difference in the gating of it. Even, for example, maybe once constant repetition of a stimuli is known to have decreased the sensitivity. You could be constantly exposing yourself to the same stimuli, for example, electric currents, heat, pain, etc. And eventually the RAS regulates it in a different manner and way, all right? So the RAS is basically made up of three broad columns that form along the length of the brainstem, the raphe nuclei, the medial group, and the lateral small cell group. It's right along here, and it connects with the hypothalamus, thalamus, cerebellum, and spinal cord. This is why anything that affects the reticular formation actually has a very, very bad impact, because the patient is almost losing all of their sensory feelings and the reactions to it. Like I already discussed, it takes it from everywhere. It can take it from, our olfactory, our auditory, our ophthalmic, etc. Regulate it, send it to the cortex, bring it back down. Now, when we talk about, okay, so we spoke about drowsiness, we spoke about the RAS, which is basically controlling our sensory system, and then we spoke about stupor. Now we come to coma and vegetative state, which are the next two consecutive ones. So what do we mean by, when do we call a patient, this patient is in coma? When do we address the patient as this patient is in vegetative state, right? So normally, you presumably, like, you're in full obviously you're in full consciousness when you're listening to this lecture. Your arousal is 100% and your awareness to your surrounding is 100%, right? There's no way you will be listening to this in the middle of, let's say, a busy mall or a party. okay? Unless your situation is dire and you have a final tomorrow, but there's no way you'd actually be doing that, right? But that's your awareness, that's your orientation, your judgment, your memory. If you're taking notes, that's part of your, perception, etc. But when a patient is in coma, their awareness as well as their arousal both is at a zero, meaning they're nil. They've got nothing. They're nothing in them, meaning their reflexes are not working, their cognition is not working, their memory is not working, their orientation is not working. None of that is working. All right. But when you look at vegetative state, what happens in the vegetative state? In the vegetative state, they regain some of the function, meaning they have 100% arousal, but their awareness is zero. It's completely lacking. And how does that work? If the patient is not aware, how does the arousal work, right? So it's like a swing balance. So you can have, so for example, some patients will have random blinking movements. They'll have random twitching of the hand. So the patient's family actually thinks that they're getting better, when in fact, this is their arousal that's working. This is not really their awareness. They're completely unaware of their surrounding. They don't know who's there. They don't know, for example, we've seen patients, family members, they say, oh, whenever I come, they blink quickly or like they move a finger. So I'm sure he knows, or the patient knows that I'm here, like, doctor, they're getting better. They're not as horrible as you say their state is. This is actually because they have 100% arousal. This has nothing to do with their awareness, right? So the patient is in vegetative state, and this has no actual effect on their prognosis, okay? Now, coma can either mean that their RAS is dysfunctional or the cortices. Why? Because even if the RAS is 100%, where does it project to? It projects to the cortex and the thalamus, right? Through the thalamus. So if the cortex is not working, even if the RAS is 100%, there's no use. That's why we mentioned specifically both hemicortices. So it has to be, because even if one side of the cortex is working, then the RAS will project towards that one side. But if both are not working, then khalas, even if this is 100%, there's no real use of our cortex, right? Because in this diagram, remember, so it has to project. It has to project somewhere. So if this whole portion is not working, then where will it project, even if this is working 100%? The stimuli will come in. It's a huge full stop over here. Okay, I hope you got the concept. Now, that is why it's important to understand that it could be either. It's not always that the patient has just the RAS. It could also be the cortices, right? So anatomically, it's just what I explained in words. It could be that it could be the brainstem, from anywhere from the caudal medulla to the rostral midbrain, or both hemispheres. Because, like I said, if one part's working, the RAS will still project to that one part. When we talk about the vegetative state, the most common causes could be cardiac arrest. Why? Because the heart stops pumping blood. When the heart starts pumping blood, what happens? The blood that is pumped from our heart is what goes to all of our organs, right? Including the brain, which gets a lot of supply from the heart. So once the blood is no longer pumping, the organs start shutting down. And one of the quickest organs to shut down is unfortunately the brain. So what happens is that there is ischemia, meaning there's decrease in blood flow, and the brain shuts down. And we all know that once the brain goes through ischemia, it can never be regenerated. Right? Tissue lost in the brain is tissue lost. You can never get it back. That is why, that's it. The patient goes into vegetative state because they lose a part of their function completely. Head injuries are also a very common mechanism because it's very obvious. They can actually have direct loss of function because of the injury due to bleeding, due to tear, due to skull fractures, etc. In the vegetative state, there is an awake appearance. Why? Because arousal is still intact, right? But unresponsive state, meaning their awareness is not there. So they will no longer be able to communicate, have judgment, orientation, all of that. Many of them were actually comatose, but eventually they move into the vegetative state because of some recovery. Eyelids are open, giving the appearance of wakefulness. A lot of the patients, we have to shut the eyelids so that they don't actually have permanent dryness, which can effectually cause corneal ulcers, etc. So in the vegetative state, because arousal is still there, they can yawn sometimes, grunting, swallowing, some type of movement. And this is usually why the relatives or anybody who's like near the patient, they feel like they're coming out of the coma, when in fact it's actually nothing. And very few times does it actually mean something, right? And respiratory and autonomic functions are all retained. This is the biggest difference between a comatose patient and vegetative a patient who is in a vegetative state. The other thing that we discuss about is minimally conscious state. What is minimally conscious state, right? So it's basically, they have severely altered consciousness, right? But there's some type of behavior that is exhibited. If a patient, they see somebody they know, they might smile, or if they see something they might like do a specific amount of action, right? So there's some form of intermediate state between stupor and coma. This is minimally conscious state, right? So it could either be from good to bad or bad to good. When we say it's good to bad, it means somebody, for example, Parkinson's, Alzheimer's, all of these diseases, which are considered as degenerative diseases, they eventually start off as good, right? They're fine, they're normal patients. They lose their consciousness slowly and they become minimally conscious. So they become just very unconscious. For example, Alzheimer's patients, eventually they even forget to drink water. So that's how bad it gets for them, right? And then it eventually can either become, it's usually permanent in this specific scenario, or it can be transient, as in some specific cases like accidents, etc. But there's also from the bad to good. When is this bad to good? So from coma, where they're like completely nothing, right? So the patient is eventually recovering from a coma and they can be minimally conscious and they can sometimes retain in the state forever, or they can just be in it for some time and then fully recover and become normal, right? So this is the example of bad to good, right? So we see both of them in minimally conscious patients. What is the diagnostic criteria? They must be able to follow simple commands like if I say, can you please blink? They can blink, right? Can you move your finger? They can move their finger. Minimal commands, like simple commands. You can't tell them, can you please tell me your full name? No, they're not going to be able to do that, right? So minimal, simple commands like, can you maybe just grunt? Can you sometimes yawn? Like simple commands that are not too complicated. We can also ask them to do yes or no. Are you thirsty? Are you hungry? Are you uncomfortable? Are you cold? So they can respond yes or no. Sometimes they'll just say, like you cannot understand what they're trying to communicate, right? This also comes under minimally conscious state. They can also be something, like I said, related to the environment. Like they don't like something, they might show some aversion. They like somebody, they might show some sign that they're happy, like a smile, etc. They are cold or something related to the environment itself. Okay. Second is, okay, now we come to the, okay, so this was all of our consciousness related disease. We spoke about drowsiness, stupor, minimally conscious state. We spoke about coma, vegetative state, and inshallah in the end we'll cover brain dead, but most of them we've covered, right? So now we're going to talk about coma mimics. What is coma mimics? These conditions look like coma, but they're not actually coma. The first one is locked-in syndrome. Locked-in syndrome mainly happens in either babies or kids that are abused. So I'm sure you've heard about shaken baby syndrome. So when they're vigorously shaken, their head wobbles up and down, and because they're so weak and you can't really protect them, it causes a laceration along the area and they permanently go to locked-in syndrome, right? It's also called a shaken baby syndrome, but in the adults, it's most common in accidents. Okay. The second one is catatonia and conversion reactions. Both of these are psychotic related episodes. We'll discuss them as we go through them. All right. So the first one we'll discuss is locked-in syndrome. What is basically locked-in syndrome? Locked-in syndrome, basically, there's a region here, the ventral pontine lesion. When there's when this area gets affected, what happens is that everything below the neck below, it's completely gone. So they have preserved consciousness, and preserved eye movement, but there's complete paralysis downward. It's mainly a motor related disease rather than a sensory related disease. All right. They have no means of producing any speech, or they can't move any limb, face, no pharyngeal movements, nothing to indicate wakefulness. But their arousal is 100%, and their awareness is also 100%. So they can cause vertical eye movements, lid elevation. So these are all things that allow the patient to communicate. So they're completely conscious. Everything is there, but there's a sensory deficit in this region. So they're basically paralyzed. So that's why it mimics a comatose state. The other one is catatonia. What is catatonia? Catatonia is basically, for example, schizophrenic patient, when they feel like they're in danger, or they sometimes genuinely believe they're dead, or this is not like them trying to fake being dead, they genuinely believe they're dead, or in states like that. So they show no voluntary movements. They actually replicate a comatose patient 100%, because you're not able to stimulate them. They don't respond to even like how they respond in stupor with like stimuli, etc., etc. Okay. But how do we actually identify that this is catatonia? There's actually a sniff test that we do where we give hydrogen. This used to be the case, but I think now it's illegal. Hydrogen peroxide to the nose. It's a nasty smell. Everybody in the room can smell. They'll immediately take their head away from the smell. So we can differentiate this as catatonia. The other thing is we can do the reflexes like calorific reflex, etc. Those things, they will immediately come out of their state, and they'll actually start becoming fine. So just to go through the slide, they blink spontaneously, they swallow, they're not really distressed, the eyes are half open, as if, light sleep, etc. Hypomobility, they do not move at all. It's one of the things in major psychosis. There's no brain damage, nothing. They're actually fine, but they feel like they're not. Conversion reactions, relatively rare, but then once you do the sniff test or the calorific reflexes, the patient is physiologically awake. They'll immediately be awake, And EEG is also confirmed just to make sure that there's nothing wrong with the patient. The other thing that we go through is the Glasgow Coma Scale, very important to memorize. They could give you a clinical scenario, and ask you to calculate the Glasgow Coma Scale. Just understand that there are three main components: eye, the verbal, and the motor. And we give points starting from 6, 5, 4. The max is 15, right? And the minimum is 3. And if the patient has 8, you intubate. 8 or below, right? So each one has a component, and you can just memorize them, but try to understand what they do rather than memorize it. So in terms of eye opening, we have the point 1 for all of them is none, meaning there's no response. Okay. Then in eye, we have first one is so when they have spontaneous eye opening, they have the highest, which is 4. When they respond only to voice, it is 3. And when it's to pain, meaning when you press the patient, etc., and their eye opens, like in terms of stupor, it is to pain. Verbal response, again, oriented 5. If they have a conversation, but for example, you're trying to ask them the name, and then they're talking to you about something else, they're very disoriented. It is a 4. They're telling you words and they're speaking, but they're making no sense. It is 3. And they're just making noises and grunts, etc. It's 2. All right. Motor is the same way. Motor we'll discuss in detail as we go through because there's like specific things. And motor 6 is obeys command. 5 is, for example, they'll tell you where the pain is, etc. They can localize pain. 4 is if you, for example, you press them hardly on specific, for example, a limb, they'll move their hand immediately from there. They withdraw from pain. 3 is flexion. 2 is extension. So this is decorticate, decerebrate, and 1 is not. So it's better to, so you must be able to memorize the GCS score because they can give you a clinical scenario and ask you to just give the score. Like they can ask you, what is the score of this patient? And you must be able to evaluate it. For coma evaluation, we check for the normal vitals. Along with that, we also do temperature, and we will check the breathing pattern. We'll see the reflexes of the pupils and fundus, the eye movements. We'll do cranial nerve examination as well as a motor evaluation. When we talk about coma, it's important to understand that there could be multiple etiologies, not just injury or something like that. So, for example, a patient also presents with fever. It could suggest a systemic infection, such as meningitis, encephalitis, or it could just be to a specific lesion that, like brucellosis, etc., specific things that could indicate that. High temperature is also if it's associated with dry skin and the temperature outside is also very high, for example, in the hot season, etc., the immediate suspicion is something like a heat stroke. So you must be able to correlate the etiology with the environment, the presentation, and the vital signs itself. When we talk about breathing for comatose patients, there is where the lesion occurs directly correlates to the type of breathing you will notice in the patient. So the first one is supratentorial. When you see supratentorial, it's about here. You have a Cheyne-Stokes pattern of breathing, which means the patient will keep breathing and then it gets irregular, and then you have a brief period where they don't breathe. So it gets quiet. And then the patient will gasp and start breathing again because obviously they need oxygen, right? Gasp, start breathing again, and then it becomes irregular and then it goes off. Again, this is Cheyne-Stokes, all right? When there's a high brainstem injury, you will see the patient hyperventilate. Usually it's this pattern. So this indicates a high brainstem injury. When there's a low brainstem injury, it's just irregular. It could indicate anything from hyperventilation to hypoventilation. This is the graph, so you can correlate that with that. What you have to understand that these points are actually important for MCQs. And these patterns are something you should be able to memorize. So learn how to identify the pattern because they can ask you the lesion that directly correlates to the injury itself, right? Now, these breathing patterns can also be influenced by other things. So it's not like a 100% diagnosis in the patient. For when there is an acid-base derangement, for example, the patient is hypoxic, hypercapnic, the patient will be hyperventilating or etc. So they could be changes like hypoxia, cardiac issues. The patient could have a pulmonary edema because of which the patient is hyperventilating, and other causes because of which they can be breathing pattern changes, right? For example, the patient could be having a panic attack, an anxiety attack. I mean, it's less. So there are other things that influence breathing pattern. So it's not like written on stone, but understand that these specific patterns for you are MCQ point of views. So they can ask you to recognize the pattern and to ask you where is the brainstem lesion. All right. We do a cranial nerve examination for almost all patients, coma or non-comatose, that present with a neurological presentation. Uh, we check mainly we do each cranial nerve, but the main ones we look for are the reflexes. We look for the pupillary right reflex, which is cranial nerve 2 and 3, the oculocephalic and the calorific ones, which involve 3, 4, 6, and 8. The corneal reflex, which is 5 and 7, and the gag reflex, right? The pupil anatomy is complicated, but let me just simplify to you. There's two things, parasympathetic and sympathetic, all right? Sympathetic dilates, parasympathetic constricts, all right? So when there's exposure of, say, light, too much light, the immediate response is to constrict. We shine light at the patient's eye and we see if it's constricting or dilating. If at This is basically the pupillary reflex. When you shine light, the patient's pupil should immediately constrict. If it does not, it indicates a lesion in the parasympathetic pathway. For example, when there is increased adrenaline, or it's like a sight to behold, or etc., the sympathetic is activated and the pupil is dilated. All right. This is the simplest way to understand the pupil, the reflexes that involve the pupils. Here you can see the clearer diagram, but this is basically the most important thing you have to understand. The afferent limb, meaning what carries through the brain, is through the optic nerve. The efferent, meaning the response, is through the parasympathetic that happens through the oculomotor nerve. And when we have, for example, an uncal herniation, it leads to a third nerve dysfunction, which will in turn disrupt this pupillary light response. There are a lot of things that actually disrupt the pupillary light response. For example, a lesion in the brain. It could be because of it could be due to multiple things, which is not very important for you right now. Just understand that it's one of the things that we use to determine in a comatose patients. Now the pupil, some of the key points is it is close to the RAS, because remember the RAS collects information from the pupils as well, from the oculomotor, from the optic as well. So it is very closely related to the RAS. The patient could have deranged lab values like hyperkalemia, hypokalemia, hypernatremia, anything, and it would not affect the pupillary reflex. It is immune to that. The size depends on the sympathetic and the parasympathetic inputs, and if there is a unilateral dilation, it causes uncal herniation. This is an MCQ, so please focus on that. We also do a funduscope examination, fundus examination, using a direct or indirect ophthalmoscope. When we do the fundus examination, some of the findings are very important. For example, papilledema, it is the fundus, the optic nerve, the optic disc basically becomes pale. This is usually due to an increase in intracranial pressure, meaning they could be a tumor, they could be a mass, they could be herniation, they could be anything that leads to an increase in the CSF, etc. This causes an increase in intracranial pressure that leads to papilledema. And the other one is you could see exudates, meaning it could be because of a hypertensive crisis, etc. You can see hemorrhages. So all of these are findings. Here you can see exudates, you can see retinopathies here. These are exudates, etc. Increased ICP. It's highly unlikely that they give you images such as these, because this is a little bit more advanced, like 5th year. But just understand, for example, papilledema, etc. That's important still. For eye movements, there's only one thing that you have to remember. We have the medial lateral fasciculus, which controls the conjugate eye movement. Done. This is the most important thing that you need to remember. It sends so if you want to look right, it'll send the information to the cranial nerve to look right, the 6th cranial nerve basically. And then as a reflex, it will send the next signal to the 3rd cranial nerve in the left side to also to look right. So basically MLF makes sure that you are looking at the same direction at the same time. It's conjugate movement. If there's an injury in the medial lateral fasciculus, this function goes away, right? You can never actually, like if you're fine right now, you can actually never look one eye left, one eye right. It's a natural response. That indicates you're perfectly fine, right? But if there's an injury, you lose this specific function. So position at rest, the patient will be looking straight ahead, or conjugate deviation. In terms of stroke, sometimes the patient can permanently be looking at one direction, and that's because of some injury caused as well, or disconjugate because they could have had an injury in the MLF. So the other one is oculocephalic reflex. If I ask you to look right, you will look right. meaning your eyes will move with you. If I ask you to look left, you look left, your eyes will move with you. However, in patients that have a positive oculocephalic reflex, which is basically doll's eye, if I were to change their head towards the right side, the eyes will still look straight. It will not move along with the head. So this is a positive oculocephalic reflex, which is also called as doll's eye. The other one is the oculovestibular reflex, which is called as the caloric test, which I'll explain in detail as we go down. Here, oculocephalic, which is doll's eye, brisk rotation of the head, the eyes held open, and you can actually see that there is there's no controversy. The movement is basically straight ahead. It's not going along with the head. All right. And when you put down, when you flex the head, the eyes look upward, meaning they should ideally look down, but instead they look straight ahead. And when you put extension, the eyes go downward. So all in all, they're maintaining one direction. They're looking straight. So it doesn't matter you move right, left, up, down, they look straight. The movement of the eyeball moves accordingly, but they look straight. Okay, so this is basically the oculocephalic reflex. The caloric reflex is basically, I put in this diagram, I hope it helps. There's a slow phase and a fast phase. It depends what water you actually put in the patient's ear. What you're trying to do is basically, there's the semicircular canals, there's the labyrinth. You're trying to send a fake current there and trying to get a reaction. That's all. When you put warm water, the slow phase, the eyes look away. All right, look away. The fast one, they realize that something's happening and they look quickly back. It's the opposite with the cold. The cold one, the eyes, they feel that sudden current and then they look towards it. Then in the fast phase, they look away. This is basically the caloric reflex test. That's it. This is nothing but you elevate the head 30 degree, all of that, and then you still 50 ml of ice or cold ice water or hot water. You can do the caloric test in both, and then you see this is the awake person. It's a horrible feeling. They feel nauseated. It's a very irritating feeling. Obviously, anyone puts water into your eyes all the way in ice cold. They feel there's nystagmus. They feel nauseated. It's very uncomfortable. But for a comatose patient, their eyes deviate towards the test, and this is like one of the clearest indication. And then you do 5 minutes, you wait 5 minutes and you do the contralateral ear. Why? Because there's a slow phase and a fast phase. If you do it immediately, you're going to confuse between the slow and the fast, because the patient could just be having the fast phase, but you're accidentally indicating it as a reflex, right? So you have to wait 5 minutes so that this whole thing finishes, the slow, the fast, everything. Then you do the next time. Some points to remember: the hemispheres are responsible for the fast component, that is, the reflex. Brainstem for the slow component. You get symmetric responses with metabolic or structural causes, asymmetric responses for the structural causes. Next reflex we talk about is the corneal reflex. Corneal reflex is, again, it's only done in terms when you want to confirm either like brain death or like we want to check the comatose patients. In normal people, we don't do it because it's extremely uncomfortable. What you do is you take a feather like thing or anything basically, and you directly apply it on the cornea. The afferent, the stimulus that takes it up to the brain, is the trigeminal. The efferent, which basically asks the cornea to move away from that stimulus or to blink, or not blink, but to move away, is the third nerve. All right. And that causes you to blink. For example, even when dust or something affects our eyes, we immediately blink, right? It's a response. That is through the facial nerve itself. Okay, so this is the corneal reflex. This is also lost in a comatose patient. Then we have gag reflex. The efferent is glossopharyngeal, and the efferent that sends back is the vagus. And the gag reflex, all you do is you open the patient's mouth and you try to stimulate it in the vulvar region. That's it. Not the vulva, sorry. In the uvula region. That's it. Now, in terms of motor anatomy, it directly correlates. Okay, so motor anatomy, there's a point here where the injury happens also relates to how much the patient is responsive. Now, this is actually decorticate. This is decerebrate. Right. So if you recall in the GCS score, we had different scoring for each of them, right? This was higher and this was lower. So if there's injury in the diencephalon region, the patient will have a decorticate position, midbrain pons, decerebrate, below if it's here and below flaccid. All right. So the motor is also the motor region also directly correlates to how much there's been an injury. So decorticate, decerebrate, all of these posturing. Decorticate, basically the arms are flexed. They're holding their arms together like this. Okay. Decerebrate, the arms are like this. So they're like stiff, like in a tension almost. So just remember that. All right. So what do we mean by multifocal myoclonus? When we mean that, it's almost like a epileptic attack. Okay. So this almost always indicates a metabolic disorder, but of course there could also be other things. And asterixis is basically you ask the patient to hold both their hands up like this. This is the palm of the patient. I hope my drawing is not the best, but you ask the patient to do that. And then you just push both the hands back, and then you'll see flapping like to and fro. Like this will just go this way and this way, like flapping of the palm. So this is a sign of metabolic encephalopathy, and it usually indicates liver diseases. All right. So this table is a cumulative summary of all of the reflex, all of the things. You can go through it as a very, very quick review. The doll's eye is very clear. I hope it makes sense to you now, more sense. Now, some other things that we do use to help diagnose comatose patients and figure out what they're going through is ABGs, arterial blood gas. We do a chemical toxicology screen. Sometimes some patients, they're in coma, you do a toxicology screen, they have high levels of lead or some type of arsenic poisoning, etc. You give them the treatment for that and they're perfectly normal afterwards. But they need to get that out of their system, right? So it's very important to do a toxic screen. You can do a head CT, MRI, an EEG, a lumbar puncture, and a CSF will help rule out anything like meningitis, etc. All right. Here, what do we mean by rostral caudal progression? This is nothing but progressive brain disease, meaning the brain impact that was already there and the disease that was already there, it's just progressing. So as you can see here, this is basically progressing and becoming worse by the second. So when we have the chain stroke pattern of breathing, we know that the injury was supratentorial, right? It was right about here. So as we go down and we have the injury level increases, it becomes hyperventilation, and then ataxic breathing, and then done. But when you reach the midbrain, it becomes respiratory arrest, and that's it. The patient can no longer breathe on their own. So it's just a progression of the brain disease itself. It can also, motor response can also indicate that. So you can see here, you have decerebrate, decorticate, and then flaccid. They just become no movement at all. Okay. What are some of the metabolic etiologies that lead to a coma? We have hypoglycemia, we have hypothyroidism, alcohol, sedatives, drugs, sometimes circulatory failure, organ failure, because organ failure, what happens is that once an organ fails, they increase in production of some stuff like lactic acid, etc. So when this happens, this will accumulate, go to the brain, and then cause a coma, etc. So in summary, when we talk about etiology of coma, it can either be structural or metabolic. Structural, we spoke about it, supratentorial, infratentorial, it could be in the hemispheres, it could be, they basically are the rostrocaudal deterioration. We look at them through the breathing, eye signs, etc. And it could be posterior fossa signs or early loss of consciousness, etc. So this is not really that important from an examination point of view. Just understand the main overall things, right? In metabolic, it's usually always symmetrical, so it's not like one leg will be working, one limb will be working, the other limb will not, etc. Pupils are spared. This is a big sign. Remember, we said that pupils are almost always spared to metabolic changes. We have ischemic encephalopathy, etc. So here we basically, it means that because of derange, for example, liver values, LFTs, jaundice, so bilirubin increases, so the brain has an increased amount of bilirubin. This leads to ischemia. So once after this happens, we have absent pupillary reflex. It means it's gotten really bad. This indicates a horrible prognosis. It's good to just understand. All right. So now we go to imaging. This is a CT and this is an MRI. A CT, the visuals should be better, but here, because of the injury, the visuals are quite bad. You can see hypodense areas, which basically indicate that there's been some form of infarction. But in the MRI, you can see them more clearly, and that's it. So I'm pretty sure you guys take this more in detail in radiology. So now we'll be discussing about some of the structural things that happen. Here you can see there is an epidural hematoma, which means there's blood here. So there's a midline shift. So ideally it should have been like this, but there is a midline shift, and now the midline is here instead of being in the center. And here you can see that there is a subdural hematoma. It's crescentric shaped, so it's not very clear. It's right about here. It's like this. And this has also caused a midline shift. Sorry. Oh, once again, I think I just, yeah. So subdural is inside the dura mater. So you can see it here. So this has also caused somewhat of a midline shift. The midline should have been here. So that's also caused a midline shift. Here, this is just injury. This patient has skull fracture. They've got hematoma here and there. They've got hydrocephalus. They've got edema because of all the injury. And they've also got air in the brain, which is pneumocephalus. So this is severe head trauma. Here you can see a cerebral abscess. This enhanced ring always indicates a cerebral abscess. We talk about herniation, which is one of the most common causes of papilledema. It can lead to a lot of deficiencies itself. The first one is subflaxial, which is basically it goes inward into that region. Second one is transtentorial. This is important. I do recall having MCQs from this region. Transtentorial, this is the tentorium region, and there is herniation inside it. The herniation could be because of increased ICP. It could be because of a mass occupying lesion. It could be because of trauma. It could be because of any of these things, right? Then you have transforaminal. Is basically, this is the foramen, and it's going through that. This will directly compress the midbrain. It can cause pupillary reflex, loss of pupillary reflex, etc. Transcranial, etc. Here, somebody who's very famous and is known to have a transcranial herniation is Malala Yousafzai. When the bullet went through her head and there was cerebral edema, she had that. So they had to take a bit of her skull and then put it in her stomach, and then they had to repair it. The edema went down, then they repaired her skull. This is just knowledge, of course. I mean, just general knowledge, but it's just easier to remember things when you correlate stuff. In a transtentorial herniation, what happens is that when the herniation happens, the brainstem is right here. So we have something called, we have the blood supply that goes through the brainstem. So when this herniation causes compression, these actually break down because they're very minute blood supply. So it's called as diurate hemorrhages, which in turn interfere with the blood supply to the brainstem, which leads to permanent damage, and it has very poor prognosis. The last thing we'll be discussing right now is brain death. So when we talk about brain death, we mean the patient is completely, the brain function has shut down completely. Nothing is working anymore, right? How do we confirm this? It's very crucial to confirm a brain death with extreme caution. Why? Because you're basically declaring the patient not fit for any more further support, etc. And the patient can't even breathe on their own. They're usually ventilated, etc. So brain death, most places, including the Kingdom of Saudi Arabia, multiple doctors, at least 2 consultants, must evaluate, sign. There is a whole team that involves, there's a neuro team that must be consulted, the cardio team, it's a whole process. So we do a neurological exam, including all the reflexes we spoke about, the cranial nerve examinations we spoke about, etc. first. If that's absent, then we do an EEG to make sure there's no brain waves, no brain function. As soon as that is absent as well, we do a radionuclide brain scanning, an angiography. What is that? We basically check the blood supply, and usually it is a dark shadow. There's nothing in the brain, just a dark shadow, and there is no brain supply. We also do a Doppler flow to see if there's any other anything, just to confirm. And when all of this is confirmed, then we declare the patient is brain dead, and the patient's family and the patient goes to DNR, which means do not resuscitate, and then the patient's family can be consulted for organ donation and other forms of end of life supportive treatment, basically. But it's very important when you declare a patient is brain dead to make sure that every single step and every single test is done properly, and you've confirmed it with 2 physicians, especially consultants, at least. So that brings us to the end of this topic. I hope everything was clear. If you've got any questions, please feel free to contact me on my email or my number. Thank you very much.